Dear audience, welcome everyone. Let me introduce myself. I am Benjamin Skribek. I am a PhD student and radiologist resident. My supervisor is Ákos Pál Deák, and my scientific methodology supervisor is Anett Szabó. We have a vision that the minimally invasive therapies will be readily available therapies in every field of medical treatments, and it can be treat various diseases. Our mission that we would like to simplify the treatments of the patient who's suffering from various diseases, mainly tumor diseases, and we would like to launch novel interventional radiological therapies in Hungary. So we have two ongoing projects. The first one is investigating the efficacy of the minimally invasive interventional therapies versus laparoscopy in the treatment of adrenal gland tumors. So the prevalence of these kind of adrenal tumors is 532 per 100,000 people. So it's a really rare disease, but if who has this kind of tumor, it has many consequences, clinical consequences. For example, if the tumor has hormone-producing possibility, it can cause high blood pressure, hypokalemia, constipation, diabetes, and other organ failures. The gold standard therapy is laparoscopic adrenalectomy, but sometimes it cannot be applicable therapy because the tumor size is really big and the tumor has hormone-producing possibility, and the patient condition do not let this therapy achieved. For example, the patient has anemia or pulmonary cardiac disease. It can be contraindicated therapy. So we would like to find alternative equal therapies. We analyzed the embolization and thermoablation procedures. These procedures usually have reduced interventional duration, decreased perioperative blood loss, and less post-operative hospitalization with faster recovery time. Our aim that we would like to compare these interventional procedures to laparoscopic adrenalectomy in the treatment of benign adrenal gland tumors. So our clinical question that are minimally invasive interventional procedures safer and more effective options for patients with benign adrenal gland tumors than laparoscopy. The population is the patients with benign adrenal gland tumors. Intervention group is the minimally interventional therapies compared to laparoscopy. We analyze the complication rate, the success rate, which is a biochemical success rate, and as secondary outcomes, operation time, postoperative recovery, perioperative blood loss, and postoperative pain treatment. We hypothesize that minimally invasive interventions are safer and more effective options than LA. We use the following search key, and we use 5 databases. After the selection process, we had 5 eligible full texts to analyze. And if we see our results, we can conclude that the complication rate is similar in these groups. But if we look closer, and the most common complication is the hypertensive crisis, and we look the odds ratio, we can conclude that if somebody has ablation procedure in the treatment phase, the patient has 8 times higher chance to have a hypertensive crisis than in the laparoscopy group. The resolution of hypertension is the next outcome. We can see that LA has more effective option to treat the benign adrenal gland tumors. It has 3 times higher chance to resolve the original problem of the tumor cause. Our manuscript has strengths. We used similar eligibility criteria full text. And we used many type of ablation procedures. We used RFAs and ethanol ablation procedures to analyze. We used only comparative studies, but these studies, all of them are retrospective studies with low number of patients, and the analyzed analyzed tumors are all of them aldosterone-producing tumors. In conclusion, we can determine that having ablation procedures, there is a higher risk of hypertensive crisis during the procedure, and it has lower biochemical effectiveness. But ablation has shorter operation time and hospital stay with decreased perioperative blood loss. The implications for practice that LA is the most appropriate procedure nowadays, and it will remain the gold standard therapy. But if LA is not applicable, ablation procedures can be alternative therapies. But we need more comparative, mainly more RCTs to strengthen our results. We sent it and submitted our manuscript to Surgery Q1 journal, and we're waiting for the response. Our next project is investigating efficacy and safety of minimally invasive interventional procedures in the treatment of low and intermediate risk prostate cancer. We can see that the second most commonly diagnosed cancer in men is the prostate cancer. The low intermediate risk prostate tumors are T1 and T2 stage tumors, and these tumors usually asymptomatic tumors. The first-line therapies are the radical prostatectomy or radiation therapies. These therapies have many complications, like erectile dysfunction, total and stress urinary incontinence, wound infection, rectal injury, etc. So we would like to find new first-line therapies, and we examined thermoablation therapies like cryo, radiofrequency, microwave, ablation therapies, and high-intensity focused ultrasound and irreversible electroporation therapies. Our aim is to find the most appropriate procedure of these minimally invasive procedures and to find the best option to treat low and intermediate risk prostate tumors. So the clinical question is which is the most appropriate therapy in the treatment of these low intermediate risk tumors. The population is the patients who has low intermediate risk prostate tumors, and we compare the minimally invasive procedures with each other and analyze the complication rate, progression-free survival, and recurrence rate. We hypothesize that if we compare these minimally invasive procedures, we can find the best option, and we can put next to the first-line therapies as an alternative option. Following our systematic search, the search was conducted in 3 databases, and after the selection process, we had almost 60 articles. We have to exclude a few articles because we have not enough articles about microwave RFA ablation and embolization, so we used only HIFU, cryoablation, and ERI techniques in our analysis. So we finished the data extraction, and next step, we have to speak about the statisticians, and you can see my summary. So I would like to thank you very much to your attention, and I would like to close my speech with Benjamin Franklin words: tell me and I forget, teach me and I remember, involve me and I learn. Thank you very much.
Julia Ács from urology.
Yes.
I have one question actually. After these ablation therapies, the tumor disappear completely, or are there any residual tumor?
Always will be residual tumor, but after the procedure, we did not call it tumor. We call it residual tissue because the residual tissue is fat necrosis, and it has, for example, about my first project, if aldosterone hormone-producing tumor has been treated, after that, there will be a small residual tissue, it's fat necrosis, and the hormone-producing availability is disappearing. So it's equal
to the surgical treatment.
The surgical treatment in this case, yes.
Could you tell me what are the side effects of this procedure?
The side effects, fever after the treatment, vomiting can be, and the most common is the hypertensive crisis during
in the case of the prostate cancer.
In the case of prostate cancer, it can be Klebby and Dindo classification we use, and it has 5 stages. The most common complication includes the first 2 stages, and these vomiting, fever, it can be incontinence also, but it can be treated as well after the procedure. So after the procedure, the people usually go home 1 or 2 days after the intervention.
And how long this procedure is?
It depends on the patient's condition, but usually everything is okay. It is about 30 minutes.
Just 30 minutes?
Just 30 minutes.
Thank you.
But it can be 1 hour and 1.5 an hour also, but it's rare condition.
Thank you.
Welcome.
Congratulations to nice presentation.
Yes.
I would like to ask regarding the first topic. Based on your data, can you choose between the RFA or alcohol ablation? Like, was there some difference between these 2 groups?
No, because we didn't do subgroup analysis because we had only 1 article which involves adrenal ablation. But the procedure is very similar, the RFA. So we cannot separate them.
Thanks. And is there some reason why you exclude malignant lesions? Malignant tumors? Sorry.
Yes. Yes, firstly, we would like to treat benign tumors, and it was the reason why we exclude malignant tumors in this case. But to treat malignant tumors, it's more difficult than benign, so it will be a real different heterogeneity if we used the malignant and benign tumors in 1 manuscript, 1 analysis. That's the reason, because the heterogeneity would be huge.
You mentioned that the incidence of adrenal gland tumors is 500.
532.
So it's very common.
Very common.
Yes. However, in each studies what you have presented, they were very low case numbers. In each study, what is the reason for a common tumor, small studies? Because
these interventional procedures are novel therapies. Mainly in Hungary, we use these therapies started to use a couple years ago, and there are no high population studies in these cases. So we have to wait a couple years, and there will be, I think, articles which include a higher population than the earlier ones. So these novel therapies and need to be widely spread in the scientific and clinical world.
Were these studies prospective or retrospective studies?
Retrospective, only retrospective, unfortunately.
Mm-hmm. Regarding your second topic, you included, you're analyzing treatments for early stage, asymptomatic, low risk prostate cancers. Which are
not asymptomatic. we analyzed patients who had symptoms also, not only asymptomatic patients, but stage 1 and stage 2 prostate cancer patients.
Okay, so these patients had, if they're progressing after the treatment, it takes very long time.
Yes.
So the observational time is also very, very crucial.
Yes.
And also the endpoint what you take, because a real progression in comparison to biochemical progression comes most probably much later.
Yes.
How do you define the progression? So which is it similar among the studies, or?
It's similar because there is a rule that every 6 and 12 months there should be prostate biopsy and MRI or CT imaging in the included studies. The protocol said that every 6 and 12 months there should be MRI examination of the prostate and prostate biopsy.
Okay, that's interesting.
Yeah.
The patient who receive HIFU, they are expected for every 3 months to get a...
No. The imaging examination after the procedure every 6 months, and the prostate biopsy after the procedure is the first biopsy is it's 12 months after the procedure. It's necessary.
Okay, so but then you have as a control group, there is the radical prostatectomy. So there is no chance to have a biopsy after the treatment because there is no prostate anymore. Yeah. So how can you then compare the endpoints between the controls and the
the radical prostatectomy is not our control group.
Sorry.
We examine these procedures and compare with each other.
Oh yes. Okay.
And find the best option.
Okay, that explains.
Yes.